Welcome to Hofstra University. I'm David REICH-HALE, the editor of Long Island Business News. Today we hold our first of 6 roundtable discussions about issues that affect the regional economy. President Obama and the U.S. Congress spent much of 2009 debating and negotiating health care reform. By year's end, a deal seemed to be in place when the Democrats finally succeeded in securing 60 votes. Then in a special election held in January, voters in Massachusetts, of all places, voted in a Republican, Scott Brown, to replace long-term national health care advocate, the late Ted Kennedy. And with that, the critical 60th Senate vote vanished, leaving the health care bills in peril. While the economy has clearly replaced health care as the issue the Obama administration is pushing, the health care crisis, as many elected officials have called it, remains. We've gathered an expert panel today to discuss health care reform and health care as a whole. With us today is Michael Dowling, the Chief Executive at North Shore Long Island Jewish Health Systems; Kevin Dahill, the CEO of the Nassau Suffolk Hospital System; Frank Branchini, President and COO of Emblem Health; Dr. Charles Rothberg, Commissioner of Government Affairs for the Medical Society of New York; and State Senator Kemp Hannon. So the healthcare overhaul that Washington leaders were pushing for the last year seems to be in major trouble, if not completely dead. But just to go back for a moment, what did you think of the bills that both the House and the Senate passed?
Well, I'll go first. We closely tracked the bills throughout the whole year, obviously. The hospitals stayed in constant touch, particularly on the Senate side with the Senate Finance Committee, where we found that the approach that was taken was probably the most balanced of all the other committees of jurisdiction. The Senate Finance Committee. You know, the context in which we supported that effort on behalf of the hospitals was one that said the alternative was staggering, quite frankly. The President early last year had proposed massive cuts to hospital reimbursement in Medicare. And then the Senate Finance Committee brought those numbers way down. And the offset for the hospitals was going to be that a sizable number of the uninsured were going to get coverage over a 10-year horizon. And the cuts were going to be prorated pursuant to that new enrollment. So that being the case, that benefited the hospitals, and we supported the Senate Finance version of the bill.
Okay.
Well, I'm not exactly sure we knew what the bill was going to look like because you had two different versions, and no bill is ever fully understood until you get the two committees of the two houses together so they draft the final version. So I thought it was a mistake for many people just to buy into one bill vis-a-vis the other, and they had some good on either side. I think generically most people would agree that it was good to provide coverage for more people that are now uninsured. That, you know, as a country, we should find a way to cover everybody, so that moving a step in that direction was a good thing. But I don't think any of us could really understand what the bills were actually going to look like till you saw the final language. And then when you finally figured out how they interpret the language, which is what the regulators do later, because I've been involved in a lot of legislation in my career, and a bill can look great, and then you get the interpretation of what people think the people who wrote the bill meant, and you end up with something that is very, very, very different. So I think that people were jumping to all sorts of immature conclusions earlier on. Just one other comment is that I am not surprised at all that the whole thing failed, because I have felt personally from day one that the President made a very, very strategic mistake in believing that he had a mandate for comprehensive reform, for trying to reform 18% of the United States economy in a very short period of time, which you cannot do. Healthcare is extraordinarily complex, and you cannot comprehensively reform healthcare all at once. There has been history to this. The United States is a country that does things incrementally. If you go through any piece of legislation or any initiative over the last 100 years, it's all been incremental. So there was a lost opportunity for the past year where they could have take some significant steps to make some significant reforms and then come back later on and build upon them. So I think now we've missed an opportunity that did exist. And in many ways, it's a little bit of a replay of what happened with the Clinton initiative back a number of years ago. So I think that's the unfortunate part of it all, despite the things that were in the bills that a lot of people didn't like. The second thing I just want to mention is that you mentioned in your introduction that the crisis in healthcare.
Well, I'll put quotes around.
Quote, yes, yeah. My view is, yeah, like in every organized system that we have, whether you're education, the banking system, the farm system, the airport security system, in every single one of them there are major deficiencies. But it doesn't mean that they're in crisis. Healthcare has been extraordinarily successful. I mean, you could argue, and I could make a real argument, that one of the issues with growth in healthcare, costs in healthcare, has been basically the fact that we are suffering from a crisis of success because we've shown massive progress over the years. So there's a lot of great things going on all the time, and there are deficiencies that need to be fixed. But the overall system isn't completely, totally broken. And we've had an avalanche of negativity, which I think serves the public inappropriately, does not serve the public well, and I think takes the debate and the agenda often in the direction that gets you to a conclusion that will cause more problems than the problem you're trying to solve.
But there are sensible reforms, which we'll get to.
Yeah, there are sensible reforms. No, it's not a question of suggesting that there are not reforms that need to be made. Sure. But this generic statements that the whole thing is a mess is something I just think that we have got to completely turn around. It's just false.
Sure. Frank?
It's very interesting. I agree almost wholeheartedly with Michael Dowling said. I would add one or two other issues that could have been, should have been articulated much better. I think when it started out, it was about health insurance reform. It became health reform. And it's not quite clear whether we're talking about reforming the whole healthcare system or reforming simply health insurance, which there are ways to reform the whole system of health insurance. I think it started out with the fundamental premise that everybody should have health insurance. And I think that's an absolute positive step. Everybody should have health insurance. I do think that to rename that as a reform of the whole healthcare system probably changes the whole debate and expands it way beyond what it was originally intended to do. So I think the definition of what we're dealing with, was it to increase insurance for those who are not insured, and the only way you can do that is with a mandate and some sort of a program that says people should have insurance, or there shouldn't be a subsidy from those who are insured to the uninsured, but everybody should have some basic catastrophic coverage. Secondly, I think the whole discussion up until the last 30, 45 days was about the public option. And I think that one of the main issues that we looked at, and I think the industry took a position on with the public option, is recognizing the fact that right now the commercial side of the insurance equation provides a major subsidy to Medicare and Medicaid. And reimbursement rates are mandated and not negotiated or agreed upon. And I think that this is one of the inherent problems in the system now. You have this mandate, this subsidy going from the commercial to government programs, and hospitals who are also in distress need to make up for that shortfall through increased reimbursement on the commercial side. So I think there are two issues. Definitional, what are you trying to deal with? Is it to reduce the uninsured? And And the second was the whole discussion that came about regarding the public option. I think Michael hit a very important point. The two bills are more dissimilar than similar. And I think both sides were so locked in.
Sure. And we'll get
it would be very difficult to get a bill coming out that would be in the middle somewhere.
And I want to get to the Senate bill in a moment, just because I know that in Albany they bemoaned that bill on both sides of the aisle. And first, we'll get to you, Dr. Rothberg.
Well, I've been invited to, and thank you for the invitation,
Sure.
to discuss this matter on several occasions. And the observation I've made is that each time I accept an invitation, by the time we sit down at the table, the legislation that is before us has changed. And if that's not confusing to us as participants, imagine how the public views this, because they have other jobs that are unrelated to health care. And I think what you're seeing happening is that people aren't sure where to put their allegiances, so what they do is they look at what they have now, and they feel threatened by any sense that that may change. Now, I have to disagree with Mr. Dowling in that he thought that it was a shame that we squandered an opportunity, but I would like to be a little bit more optimistic and say that the apparent or interim failure of legislation to move forward might be a form of progress in itself, because we have identified what things are workable, what things are not workable, and what different stakeholders desire in their legislation. And I'd like to look at that a little bit more optimistically. And I have to disagree with the CEO of Emblem Health in that I don't know that the original purpose of health systems reform was to provide insurance for everybody. I think that it was very simple what we were trying to do, or at least what I think we were trying to do, and that is we wanted to provide access to care for everybody, and if insurance was the logical way to fund that, then insurance should be provided. But I think we needed to look at it from a point of view of providing access to patients for their care, and to be able to sustain the system, which meant that we had to have some acknowledgement about the costs and what that might be going forward. And I think if we can rein in the discussion to those two elements, I think we can make real progress, all of us. Senator.
I think we've in an age of information, even of health, we have not been able to give the general public information about what the health system is. I don't think people understand why it's good to have other people have health care insurance. You know, certainly you want your own, but you don't understand why everybody else should have it. You don't understand that the more universal there is, then costs can be lowered for everybody. We can have better research, we can have the better care. It's the difference between if just 2 or 3 people have a telephone versus 1 million people have a phone. Because 2 or 3 people having a phone is useless. 1 million people means you can talk to everybody. The same way that network works for health insurance. That never did come across. And what, therefore, people were starting to look at on the outside, reading those letters or those articles you referred to, was they knew there was taxes involved. They knew they had, if you were in Medicare, they were going to have $500 million in savings. Well, is that taking it away from me? If you refuse to get the insurance mandate, you'd pay a penalty. Well, why do I have the mandate to begin with, and then I have to pay a penalty? There were taxes on the high-income people. There are taxes on people. If you had a good health plan now, it began to look like a traditional welfare program. And I think that's the guts of it. In the middle of a recession, you're being asked to give more. You didn't see the benefit of getting more, and the reaction has been the way it's come about.
And the Senate bill, I know in Albany there was a lot of pushback.
Well, the difficulty with the entire reform was that what was happening with 2 major deterrents in New York. One was we were not going to get the same rewards other states would get for having already had coverage beyond what is required. And we have Family Health Plus, we have Child Health Plus, we have Healthy New York. We have really done a great deal to expand coverage in New York. But we were going to get no money out of that. Every other state in the nation would be getting money when they raised their eligibility limits. The second part, which goes to, and this reason is why Mr. Branchini is right about the insurance reform, so much of both bills, Senate and federal, are about changing insurance rules. We would have a community rating, so you wouldn't have a differentiation in regard to the premium charge depending on age. Well, the difficulty there is New York's had a pure community rating for over a decade, but the federal government's proposal in either of the two bills was not for the same thing. So meshing that would have been extraordinarily difficult. We already have a pre-existing condition. There was going to, again, be a different provision in the federal bills. Meshing that, once again, would be different. And then last, they were going to set up high-risk pools, so people who couldn't afford insurance, it wouldn't be the burden entirely of the providers. Those pools wouldn't mesh with what New York has done. So we were getting actually penalized for having been innovative in our thinking about health insurance and health care.
Now, what's next? Or better yet, what should be next? What would be sensible healthcare reform?
Well, it's kind of interesting as we go around the table that there is not even agreement among the four of us as what the bill was intended to do to begin with. And that obviously shows you that there's a real disconnect, which is part of the essence of the problem that the President has had. What's next? First of all, understand that an awful lot of reform is going on and has been going on for a long time. It's not like everything is completely stagnant. And then you have to have a federal piece of legislation that sets the ball in motion and is going to be somewhat of a panacea for everything. I mean, New York has been a leader in the health reform movement, as the Senator says. And there has been extraordinary improvements and demonstration projects going on all over the country over the last couple of years about how they do things differently. And reform, at the end of the day, has to be done locally. I mean, I'm a big believer that most reform, if it is ever going to be practical and real, is going to happen locally anyway. And I agree with Frank that, well, the essence of the legislation here appears to have been more about insurance reform. You're never going to change, healthcare delivery or access unless you get to changing some of the delivery reforms that we need to do. So what I think, there's one option. They may have the possibility of getting a couple of pieces of the two bills and putting them together so you could maybe get a piece of legislation. So you kind of focus it down, you narrow it, and you say, if I were down there, I'd be trying to figure out if there was a way to do that. You take 3 pieces of this and 2 pieces of this, you narrow the scope, you do something that is real, and you say, let's see if we can get a piece of legislation forward. I don't know if the politics will allow it. But even if the bill, if nothing happens, I believe the essence of the reform movement will continue anyway, because there's an awful lot going on in large health systems around the country, around issues around dealing with overutilization, dealing with readmissions to the hospital, pay for performance demonstration projects. One of the great things in the bill was it would allow for a lot more comprehensive demonstrations. They can still be done, because quite a bit of what was in statute, I believe, can be done from a regulation point of view. Just the regulators can
drill down. Talk about what pay for performance.
Pay for performance basically means that you, instead of paying for just episodes of care or paying piecework, that you can, and some of these demonstrations have already occurred, where you provide a pot of money for the management of the care over a continuum, and you say to a provider, large providers, you have to manage the totality of the care here, and if you do well, you get paid more. If you do poorly, you get paid less. Now, some of these demonstrations have been going on, very innovative. They're learning labs that you need to learn from so that you can extrapolate and do something larger. I mean, part of the frustrating part of the debate over the last couple of months was, including when the President would say, well, the Mayo Clinic does everything wonderfully, so if everybody did what the Mayo Clinic did, it would be wonderful. Well, that shows an extraordinary naivete. You cannot replicate what the Mayo Clinic does in most parts of the United States, but you can replicate the essence of some of the things that they do by doing it differently in different places, and that you can't legislate. That has to be done locally, incrementally, and innovatively, consistent with the circumstances at the local level. So I think that process is moving along. And I can tell you from somebody that's the head of one of the largest health systems in the country, we're going to be moving that agenda along anyway, irrespective of what goes on at the federal level. But one last comment, going back to what Frank said, because he raises something that I don't think the public understands at all. In fact, I don't think most policymakers understand. And Senator Hannon understands, because he's one of the more knowledgeable people on healthcare in the state. And that's the cross-subsidy between the private insurance and the public payers. If you're running a hospital that's there, if you're running hospital systems, You get paid for Medicare and Medicaid, and there is no way you can survive on Medicaid and Medicare payments. They pay you too little. The way you survive is you get enhanced payments from commercial insurers, and that's the big cross subsidy. Going forward, if the federal government continues to ratchet down Medicare payments inappropriately, now there's always efficiencies you can get, I'm not arguing that, but if you continually over time ratchet down that Medicare payment, there will not be the ability for the commercial side to sustain the subsidy. And you'll end up with eliminating the possibility or the probability that you can do any of these reforms locally. That's a fundamental core problem that policymakers got to get to understand, that you cannot change Medicare payments without understanding the corresponding implication to the deliverers of health care and what it does on the private side. That's a huge issue.
If we took the federal government out of it and just spoke locally, Albany, is there anything in Albany that needs to be done that hasn't been?
You know, the subsidy is a major problem. The calculation, particularly even with Medicaid, I mean, Michael mentions Medicare, but Medicaid is a big issue also in terms of the subsidy. But I think there's a very fundamental definitional issue. When things began to change maybe 10, 15 years ago, and we moved the business I'm in insurance from protection to benefits. Everything is about benefits without the protection. And if you go back 15 years ago, it's sort of an incremental approach. When Medicare was coming out to provide catastrophic coverage, would have been a very major step in terms of reducing the cost of health insurance, which is fundamental to the problem because you can't have access, true access, unless people have a way to pay for the access. You can't run a hospital if 30% of the people coming in have no way to pay the bill. And that payment then gets tacked on to individuals who have insurance. So you've got to make a fundamental distinction between benefits and protection. If you were to, as New York State has done with pooling, take the large catastrophic payments and sort of pool it across the whole population, you would see premium rates drop significantly because over time what's happening, and we're into what they call an underwriting or a black hole cycle. People who are more healthier people drop insurance, they take a bet because they don't want to pay $12,000, $15,000 a year. What that leaves you with is a pool of insured who are higher risk with more expenditures, and it almost explodes geometrically, the cost, the insurance premiums. So some sort of pooling, it's an incremental approach, and I give that as an example of how, and a thoughtful way to move incrementally. I don't think you can change the whole healthcare system. That's a long-term project. Hospitals have to change, individuals have to change their behavior, better incentives have to be developed for simple concept of getting more physicians into primary care, which I think is absolutely a fundamental change in the system, but you've got to change the incentives to get individuals in. You've got to recognize increased compensation to primary care physicians. But these are incremental steps. And I do think, by the way, nothing at all will set it back as it did with the Clinton program many years. It's becoming a political third rail.
Myself?
Yep.
Let me just backtrack to Mr. Dowling's point that the public may or may not understand the enormity of the public component of paying for health care. Can you estimate what portion of your payer mix is Medicare and Medicaid? It's over 50%.
There's a 15%,
Yeah.
20%.
56%.
Yeah, because people might say Medicare and they think of grandma as just a small part of their family, but it's a significant part, I expect, of healthcare expenditure.
Pretty much the standard hospital across the country, about 40% of their revenue is Medicare. And by the way, that percentage is going to grow because as people get old, Medicare is the only option. I mean, everybody's going to be potentially a Medicare recipient, a Medicare patient, if they live long enough. And we all hope to live that long.
And I think you made an important point, that even if it's a small cross-subsidy today, it's a cross-subsidy for a very large part of your revenue pool.
And this leveraging effect.
Yes, and
Because of the cycle.
There's another phenomenon that Albany, and I'm not happy about it, has seen. We've expanded the number of people who get coverage, and it's gone up significantly. So there's an enormous new pool of people coming to a hospital, a nursing home, a home health care agency, and saying, I'd like to be cared for, to the physician. At the same time, we've had this unfortunate series of hidden taxes that people don't see. They talk about an assessment on a hospital. We put $1 billion of taxes collectively on New York State health insurers last year. And then people wonder why their premiums are going up. $1 billion. They can't absorb it. They're not rich. So that all of these hidden taxes, they have the money, but how much do you pass through? 85% of every dollar you get goes right back out in terms of medical coverage. So there's just an illusion that you can separate out who you're providing for with how you're providing for it. At some point, there's a breaking point, and hospitals, or as we've seen, hospitals can go out of business. Nursing homes can go out of business, and that's going to be the real crisis should that occur.
You know, we have a great lab experiment taking place in Massachusetts as we all sit here. And it's a good news, troublesome news story. The good news is that through mandates and reshuffling, they did open up access and coverage to a point where I think we're at 97% now of the population. Well, guess what happened? Costs spiraled upwards and out of control. Boston City Medical Center was on the brink of bankruptcy because of all the people flocking in now. Now that they've got coverage, they're going to access the system. A number of policy issues were raised during this federal debate that got skirted because they were politically charged. Let me give you an example. End-of-life issues. More damage was done to palliative care and hospice care, in my opinion, by the outlandish charges around death panels and all that stuff that went on in the summer. But that issue of end-of-life care is one that should not be lost. And it should not be one that is politicized. It should be one that is discussed openly and freely. We have too many patients, and even Mike would agree with this, too many patients dying in our intensive care units when there is a much more appropriate setting from a patient's point of view and a family's point of view for that patient's end-of-life care. And so when we allow a political system, with all deference to the senator, when we allow politics to take over these policy discussions, we lose, as in healthcare loses an opportunity to continue to incrementally reform the way in which we deliver care. So I think that the opportunity that this now presents is that there should be a wake-up call for all of us in healthcare to look at some of these policies that were raised, these policy issues, and go to government with suggestions and proposals. Rather than the White House delegating this to Congress, they should delegate it to the leadership in healthcare to come back to them with proposals and suggestions.
Now, pre-existing conditions, I know the insurance industry has been hammered for not covering pre-existing conditions. Should that be done away with? And also, how much does that cost hospitals and the healthcare industry as a whole if the insurers are not covering?
I think it should be, and New York State has gone in that direction. I think that the medical underwriting is a real issue in terms of our industry. But I think you can only, I think part of that equation, however, is to provide much more universal coverage. I mean, the issue you have with the medical underwriting, and New York State really doesn't have this, is people will choose to take insurance only at the point at which they have catastrophic needs. And there is no dollar price you can put on what the premium will be. I mean, the premium would be infinite. It'll be exactly what the cost of the end of life is. or the sustaining of life. And but in order to really make that work, of course, in health reform, you've got to have everybody with some level of coverage so that the risk is being spread. And that's fundamental, I think, to the issue. Otherwise, you cannot have it. I mean, all of us are going to have catastrophic costs at some point. That's the reality of it.
It's just when.
So, it's just when, and if we look at our premiums that are paid, basically you can consider it like a savings, because eventually you will spend it. It's a matter of time. You will consume it. In our business, almost 60%, 70% of our costs are incurred by 5 to 10% of our people in the last 6 months of their life. And you get into better care at the end stage. I mean, this is difficult to talk about, but much better care, more palliative and compassionate care. Because it's true, people are dying in the ICU. People, they have no alternative. Where do they go?
I think you're raising a very interesting issue, and Kevin did the same. There are things that we are afraid to talk about, and there are things that we talk an awful lot about, but we talk about them incorrectly. A big part of the discussion during the last year has been about how the whole purpose of this reform was to reduce costs. There wasn't a thing in the statute to reduce costs. Zero. Most of what was in the bill would increase cost. And the argument that you can become so efficient to offset the fantastic cost growth tied to all of the other parts of the bill, like universal coverage and everything, is ludicrous. And there are things we need to talk about, such as at least 58%, a half to two-thirds of cost growth in healthcare over the last couple of decades has been tied to progress. New developments, new tests, new ideas, new treatments. Things that we can do that we couldn't do before. When you can't do something, it doesn't cost you to do it because you can't do it. But when science progresses at such a phenomenal pace to allow you to do things you couldn't do before, you now have to provide it, if you so choose, and more people want it. So we take great satisfaction out of the progress associated with the science of medicine in the United States. What physicians can do is extraordinary. But that carries with it extraordinary cost. In fact, unlimited. It is very appropriate on the end-of-life issues because of the ability of what we can do toward the end of life. That keeps people alive for an awful long time, probably in inappropriate places, which I agree with Kevin. The second issue that we don't like to talk about as Americans is that the reason, and the implication is that cost growth is driven because of what hospitals do and doctors do, right? But cost growth is driven in part also by what we all do, which is lifestyle. You walk around a mall on the weekend and you watch, it's like an obesity fail. And you ask yourself, did I cause this? You know, did I make these people obese? No, they did. Okay? And our whole lifestyle is driven in this direction. Yet, we're very timid about trying to deal with it. And we argue that prevention would save money, yet prevention is a good public policy issue, but there's no evidence that most of it saves money. And then you've got the aging of the population. So if you want to deal with the cost growth issue, you've got to tackle some of these. And you've got to tackle one other fundamental issue that nobody wants to touch, and anybody that has done it in the past has been politically dead. We have to decide about whether or not, over time, we need to limit what people are entitled to. You know, it's called, what's the word, what do they call it? Huh? No, but rationing. It's called rationing, right?
Not a politically popular word.
No, but let's just, if science progresses at the rate it's progressing, then you cannot continue to talk about reducing, because in every other country in the world, right, they do some form of rationing, right, formalized. And I don't know how it is we can address the cost issue, because we fool ourselves all the time of saying that all of this stuff will cost money. It will save money, all of the stuff we're now doing will not. So I think there needs to be public debate on this.
I would like to respond to that, because I would like to be optimistic enough to think that we're not at the phase where rationing is our only remedy here. And you actually brought up an excellent point, and I know that your institutions are very active in this, and that is finding innovative ways to innovate the delivery system. And in your institution, because you're larger and because you have different classes of providers under your umbrella and under one roof, you're able to do things that involve collaborative efforts between the different classes of providers. And you either accomplish better outcomes or more cost-effective outcomes with that. Most everybody else finds that there's a tremendous hurdle to doing that, and so we're relegated to things like demonstration projects, and that's all that the pending legislation would have offered. But a lot of these things have been demonstrated before, and because of the legal environment we're in, particularly antitrust, people in your position and people that I represent can't get together and say, let's do this together, and we'll make the system more cost-effective and with better outcomes. How do you respond to that?
Well, the last point, I completely agree that it's kind of interesting, because the debate has been about how we should coordinate care, we should all work together, we'll have seamless transitions of care between doctors and hospitals and non-acute facilities. Yet there's a whole series of federal laws that prevent you from doing it. Yet nothing in the legislation, you know, actually address that issue. I mean, should doctors and hospitals be able to work much more collectively together? We have to work through 100,000 rules to figure out the little narrow bands in which we can be able to do this. And it's pretty ridiculous. It's a big problem. Now, I also agree with you that big systems like ours, and we hope, and we try to be very innovative, is that we are probably able to do things better than a lot of others because of our size and scale, and because of we constantly be trying to innovative. But on the and it is possible that we'll be able to reduce some costs or slow the growth of the cost growth. But when you look at it overall from an aggregate in the United States, in terms of whether or not you go from 17% GNP and healthcare costs to 20%, you know, you can always show a savings in a micro area. The question is whether or not, from a national sense, you can show savings on an aggregate point of view. And I'm not sure you can over in the long term unless you address some of these other things I mentioned. But on the issues around getting physicians and hospitals together, I think the future has to be hospitals and physicians working very, very, very closely together, because we're not enemies here. I also think that, you know, we get ourselves in a situation sometimes where we fight back and forth with insurance companies, but I don't think we're also the enemies either. That there has to be ways that we work together, and we do, by the way. There's an awful lot of collaboration that goes on. So I think all of these things are very good things that can have a positive impact. But the science is marching ahead faster than our ability to innovate from a delivery point of view.
But don't you think we need to shift the way that we think about the collaboration between the different provider classes, particularly hospitals and physicians?
Well, I would argue that one of the things we should even put more emphasis on is how each of the people in the health delivery system are doing their things, hospitals or doctors or nursing homes, because we've kept three different silos: affordability, access, and quality. But what we've actually started to do in the past decade is to start to look at the quality and realize that when we establish some protocols as to how people should be treating a different disease in terms of management, not in terms of a new drug or a new medical device, but in terms of management, that we can keep people from staying in a hospital an extra few days. We can improve their outcomes as to how their hospital stay is going to be. We can improve their after-stay care. And we started to erect things such as hospital report cards. And all of a sudden, through looking at the clinical adoption of hospital report cards, not just billing, that there's been some decent standards. They've actually come out of Washington. They drive someone like Michael Dowling crazy because now he has to run a hospital and it's reported out there. We've done some of the things for doctors, reporting their malpractice records on the internet, but we've set up these standards. And, it's not a happy thing.
I was going to say, is that supposed to please us?
No, it doesn't. No, but it pleases the patients. And at the end of the day, the affordability, the access, and the quality is for the patient. And so when I get the chance to deal with public policy in health, I'm not trying to please any of the sectors you represent. What I'm ultimately saying is, how is the patient going to be bettered on this? And we have to move that forward.
I think that's what we're saying.
I just one comment on that, though, is, the physician's defense here, and I believe this is has to be a real.
I tell you.
Well, absolutely, right now, I mean, believe me, I believe that you, because, given the abundance of lawyers we have in the United States, and the fact that we continue to graduate them, I mean, I think productivity would go up if you actually put a moratorium on lawyers being graduated out of law schools. But anybody can sue anybody for anything without having any justification for the lawsuit. So the fact that there are lawsuits against a doctor doesn't necessarily mean that's a bad physician. And I think that we have to be a little bit careful about this, because you can zap a lawsuit on anybody for anything. I mean, I'm sure that there's a lawyer out there looking at this who thinks that they could probably sue us for something we say here today. So I think we got to be just a little bit careful. I mean, you asked a question earlier about one of the things Albany can do, and I know the senator agrees with me on this. And you definitely need tort reform in New York State, because and I know he agrees with that, but I don't ever see that happening under the current leadership in Albany, unfortunately.
How expensive how much is malpractice costing the healthcare industry
It's
in New York?
extraordinary. It is outrageous. And on Long Island, it's even more outrageous. We have obstetricians who are paying close to $200,000 a year just for their malpractice insurance before they've done anything else. And to the extent you're looking at the average age of an obstetrician on Long Island, he or she, it's going up. I don't know how we replace them. It's very difficult. The burden is being shifted to the hospitals, but some of the numbers that are cited out there by hospitals are just staggering. $10,000 a year per delivery. So when people are looking about the cost of health costs or health insurance, it's right there in the malpractice system. And you just hear other states making changes, and there's a very salutary effect to benefit that system in those states.
So what are some of the changes that you've pitched?
I have legislation in that would set up a whole system for the child born with a mental impairment. Right now, even though there might be no malpractice whatsoever, no missing of the, wrong use of the forceps or anything like that, if a child has a mental impairment, then that's almost a suit that's guaranteed to result in an award. Why don't we set up, and it only benefits, by statistics, 1/3 of the kids born with that syndrome. The other 2/3, somehow society takes care of. My thought is you just set up a whole fund, you set up a whole system, you automatically take care of it, remove it from the tort system, and let people try to take care of the patient again, instead of just rewarding someplace in the system.
There's a good demonstration going on in the Bronx, in which a specialty court has been established with a judge who's become very well informed on medical issues and medical malpractice, who can hold both plaintiff's counsel and defense counsel accountable for certain procedures and so on, just wringing out the efficiency issues in moving matters along. That could lead to holding attorneys accountable for cases that they bring that maybe were not appropriate to bring. But just wringing out the efficiencies through a specialty court with a judge who hears the matter and makes a decision could go a long way. We've put that forward as well as a proposal.
And there's another cost, and that is the utilization and the protective aspect of the consumption of medical care, because you don't know what's going to come down the road. It's interesting about the quality, just to get back to that for a second. If I run a hospital and I'm picked, I do the best cardiac procedures around, eventually all the sicker patients will come to me. And you'll have a higher mortality rate, which would affect your quality. So it's very complicated to get it all risk adjusted so that you can really focus in on quality and scorecards and report cards. It's a complex issue. It sounds easy to the public, but it's not that easy. I mean, we were out looking at North Shore 2 months ago in their one aspect of their critical care. And it's the type of an operation facility where you're going to attract the sicker, more catastrophic cases. I say this all the time in our meetings. In the long run, you know, we're all, as Keynes said, dead. But because he's built the state-of-the-art, he's going to attract the sickest, more catastrophic cases, and there'll be a higher mortality rate. You can see that in certain places, and that's a reality of how do you factor that in? It's not easy. It becomes a political.
Getting back to Senator Hannon's legislation, the Medical Society would support that because it would tend to compensate people quickly, and certainly that's the whole goal of the system, is to compensate people. They need the money. It would be fair. It wouldn't have the arbitrary nature of the system we have now. And it would be very predictable, which helps all of the business entities to, to plan. And most importantly, it protects the public, because that's what the goal of any liability system is. And right now, I think the current system, all the shortcomings have been identified, but what it doesn't do is what it's supposed to do, which is to protect the public. It's the most inefficient means of doing that. It takes many years, sometimes 8 years, to settle a case like that.
Easily.
And it costs the system much more than the person who's being compensated actually derives. So we really appreciate what you're doing.
One of the things I think that we've got to keep in mind here is that it's very easy in discussions like this to become very pessimistic and frustrated and annoyed. But it's in part because this healthcare is so extraordinarily complex. It has so many pieces to it, and it's an evolving science all the time. But there are enormous things that we can continue to do. And I would strongly urge at the federal level that they allow a lot more, innovative demonstration projects around how it is to pay for healthcare differently, that requires people to collaborate and work together, and also at the state level urge that, because there are organizations such as ours and others that are more than willing to innovate and do things differently than we now do it. Because if you're a leader in this business, you should never be satisfied with what you do. You should always be figuring out how to push the envelope and do it differently. And the status quo should never be what we're satisfied with. And working with payers, which of course is the other commercial payers, and they are the governmental payers, to allow us to innovate more. Break down the rules that prevent the various parts of the provider network from working together without having to worry and look behind your back every moment that maybe if you collaborate in a certain way, you're going to get in real trouble. And because unless you break those kinds of barriers down, it is ridiculous to go around talking about how we should coordinate care all the time. Everybody wants to do that. I had a meeting last night with 100 physicians that talking about this and trying to figure out how do you do it given the plethora of constraints that currently exist in statute to stop you from doing it. It makes no sense. And I would, at the state level, at the federal level, urge that we we continue to focus on covering more of the uninsured. You may not be able to do it all at once, but you definitely can find a way to cover the uninsured that are working, for example, or to expand coverage for children. We have a great lesson in New York. I was there when we did Child Health Plus, and very involved in that, as the Senator knows. That made a huge change in the way New York State provides coverage. Now it's Family Health Plus, it expanded, it was done incrementally. Provide continuing resources for the advancement of information technology so that you can manage care and be transparent. I'm a big believer in transparency, and I'm a big believer in public reporting. I believe that that's good in the long run. So there are a lot of things that can happen and are happening and that will continue to happen. And I would say for the government at the moment, which I don't see as the bad guy in this, because they have their own constraints from their side. This is not bad guy, good guy. There's too much of that stuff going on that we've got to get away from. But take a look at the barriers that prevents us from doing the things that we would like to do and figure out a way to eliminate those barriers. And innovation will just sprout. In large health systems like mine, where we have nursing homes and palliative care and home care and hospitals and ambulatory sites, I got the whole thing. My job is to try to figure out from a patient point of view, how do I move the patient around seamlessly without going into all the problems, especially with physicians and hospitals, and come out of patient coming out at the end with optimum quality that is publicly reported. That's all doable. That's all doable. That's where reform, I believe, is going to bear the fruit of success. And that's where it has to lay.
Unfortunately, we are out of time. We could probably go another half hour. I appreciate the time, gentlemen. Thank you very much.
Thank you.
Thank you.
And have a good day.